Welcome to The Art of Medicine, the program that explores the arts, business, and clinical aspects of the practice of medicine. I'm your host, Dr. Andrew Wilner. Today, I have the pleasure of speaking with Dr. Bradley Block, host of the podcast Physician's Guide to Doctoring. Brad is an ear, nose, and throat surgeon in private practice. He's going to share his tips for seeing patients efficiently while offering compassionate care. But first, I'd like to thank our sponsor, locumstory.com. Maybe you're curious about locums and how it might fit into your career story. But do you know all the different reasons physicians choose locums and how it works for them? At locumstory.com, you can hear firsthand stories as diverse as physicians themselves. There's not one solution for everyone. The variety of opportunities might surprise you. Locum Story is an unbiased educational resource. It has tools that let you explore trends in your specialty and compare different locums agencies. There's even a simple quiz to see if locums is right for you. Do your own research at locumstory.com. It's easy. And one more thing, thanks for joining us. The Art of Medicine is available on YouTube and wherever you get your podcasts. Alexa will find it for you too. And now to my guest, Dr. Bradley Block. Welcome.
Dr. Wilner, thanks so much for having me. I've really been looking forward to this.
Brad, well, you were kind enough to give me a spot on your podcast, and I think we had a pretty good discussion. And I spoke with my wife earlier today, and she listened to it. And I said, "How was it?" And she said it was good, except you were the only one talking. You didn't give the other guy a chance to talk. So
Well, it's
now's
an
your chance,
interview.
bud.
It was about locum tenens. I've never done locum tenens, and you're the expert. You've written a whole book on it, so of course you're going to be the only one. You're going to be the only one talking.
Thanks for your defense. I will relay that to her. So now it's your turn. So tell me a little bit about your training and background.
So, I did med school in Buffalo. I'm from New York, so I went to a New York State school, SUNY Buffalo. Did my residency at Georgetown, and then I'm one of the few people who, right out of residency, joined a practice that I'm still at. I've been there for 12 years and have no plans on leaving or changing jobs. I've been a partner there for 7 of those years, almost 7 of those years. So I'm drinking the Kool-Aid. I love my practice, and I'm not going anywhere.
All right. So that begs the question, how come you're not burned out?
Who says I wasn't? I've certainly experienced some of the symptoms of burnout, like Maslach's classic burnout. But there's some things that I've done that have helped me along the way, and just life and the practice of medicine. It still affects all of us, even those that own our practice. Like, listen, my practice is great. I'm gonna advertise for my practice right now because I'm a true believer. We're a bunch of ENTs and allergists who own the practice, but we don't have to run the day to day because there are 170 partners, 250 physicians, and everyone's got a clear path to full equity partnership. The people who really run the practice are elected partners who see patients every day, same as the rest of us. So they're not going to do things that are going to make us work harder for a couple of extra bucks. They're going to make decisions that make our lives better. And if it's going to make us more money, it's got to be something that's a big deal, right? Because it's not going to move the needle a big amount. It's not going to be worth it. So, so, you know,
Well, I think
what's better than that? What
I
what could be a better situation than that?
I think it's essential because, well, first of all, there's this national trend to employment of physicians. And I think that that in and of itself isn't necessarily bad. But the problem is that the employers, by and large, are not physicians and they don't really understand, they're administrators, but they don't really understand what physicians value and how to, make their day better. So having physicians in charge, that sounds like the way to go. So I would say that is secret number one to avoiding burnout in a practice, that the doctors ought to be at the C-suite level making the important decisions.
And within our practice, if there's something that you feel strongly about that you're particularly capable at, like let's say you like building websites, well, then you should be on the committee that's building websites. You don't have to run the whole practice, but you know what? Help us run that aspect better. And something that I did is I created the patient experience committee so that we get together. It used to be every other month, but now because things have actually gotten better, we meet less frequently than that. So our goal is to make sure that the patient experience and the staff experience is as good as possible. So people, this becomes a place where people want to work, where we can be proud of. So, that was something that was really important to me and something that actually I've learned about through my podcast because I've had a lot of guests that talk about patient experience. And so, yeah, it's also, you know, um, leadership, I think, is one of the things that could help with burnout as well, right? Another creative outlet, some way other than just because one of the things that's led me towards burnout was just the grind of seeing patients over and over and every single day for similar complaints, saying the same things over and over. And just kind of like you end up distancing yourself a little from it, and you just get home exhausted. So emotional exhaustion is one of the symptoms of burnout. Depersonalization, one of the symptoms of burnout. Um so the podcast, and I'm sure you feel the same way, it's a creative outlet that helps me, gives me something else to look forward to, helps me not burn out because it's just having a creative outlet, whether it's related to medicine or not. And leadership within medicine also I would view as a creative outlet because it lets you use a different skill set, right? We experience this thing called hedonic adaptation, which anyone who's bought a fancy car knows what hedonic adaptation is. Like it's exciting to shop for the car. It's exciting to think about it. It's exciting to buy it and then have it for a little while, but eventually it just stops being exciting. You get adapted to it and it stops bringing you joy, yet your monthly payments are still super high. So, that's why buying a fancy car is not a good use of your hard-earned dollars. And the same thing can happen in your job where it just stops being as stimulating and exciting as it once was. So you need to find ways to keep it like that. And you cover similar stuff in your podcast as I do in mine. Um, there are things that we learn on our shows that we can then incorporate into our practices. So we have guests on that can help you be a better doctor, and then it allows you to incorporate it into your practice, and it kind of refreshes you a bit. It helps keep it new and interesting, and then you realize, you know what? Now I have another question. I'm going to get another guest on that can answer that question, and then it's an iterative process and allows you to keep improving your skills more and more. And what we talk a lot about is that doctor-patient interaction.
Yes. Well, I'll add another thing that I try and do to keep things lively and stimulating is just before we started this podcast today, I just submitted an abstract to the American Academy of Neurology on an interesting case. So, reminded me of being a resident. What's really, really interesting about this? Now, I
About
want
what I do,
tips.
yeah.
I want tips. How do you be efficient? Because you said, well, you're seeing the same thing over and over again, but for that patient, it's the first time they've had that problem, right? And it's not over and over again for them, at least most of them, right? So how can you be efficient and compassionate at the same time?
At the same time, yeah. I mean, it's about not just respecting the patient in the room, but it's also about respecting the patient in the waiting room because you can be compassionate and slow, and you can be compassionate and not. So, there are some things that you can do. And actually, I just had someone on my show that said he wrote a book called "How to Make People Like You in 90 Seconds or Less," right? And so, yeah, and so there are a couple things in that. When you walk, that things that when you hear them, you're like, "That's so intuitive,"
Mm.
but like, of course, but we don't necessarily do them. So one of his tips was look the patient in the eye. Of course you're going to look the patient in the eye. Yeah, but look them in enough to notice their eye color. So if you do that and you check that box, you've made sure you've actually made eye contact long enough to notice, but not long enough, too long that you're creepy. So, that's going to give them confidence that you're actually interested in them. If you've got your nose in your computer then you haven't given this nonverbal cue that you're actually interested in them as a person, not just another problem to solve, another patient, because they want you to not just fix their problem, they want you to care about them. So if you can connect with them, then then the visit will be more fulfilling for them. Yes, well, but isn't that going to make things longer? No. And the reason is if you can connect efficiently, then they're going to have more trust in you. You're going to be less, they're going to be more receptive to your recommendations. They're going to push back less, and have less doubt in your recommendations because they're going to know that you really care about them, and it's actually going to make things more efficient. Another thing that you can do is recognize that your patients often have a question behind a question, meaning they may not be asking you what's really worrying them. And so they might perseverate on some of their symptoms, and you're not able to get past this perseveration because you haven't really addressed why they're there. Like a patient comes to see me for hoarseness, and you're like, well, it looks like you've got something called presbylarynx. It happens with aging. The vocal tendons get a little more loose, and it can lead to some breathiness in your voice. But you haven't said what they want to hear, which is they don't have vocal cord cancer. They don't have throat cancer. So, you have to ask them this important question. And that
God, what?
important question
Let me
is
interrupt. What was it? Presby? What did they call it?
presbylarynx.
Yeah, well, I'm interrupting because I had that. I went to the doctor and exactly that. I was afraid I had throat cancer. That's exactly what my concern was. And I was kind of, mildly offended, but incredibly relieved when the diagnosis was, well, your vocal cords are too old and sagging. Presbylarynx.
Presbylarynx, yeah.
So it's a good
But
thing to have, but it's not really flattering. Okay.
no, 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 no. But but I think it's important to verbalize you don't have throat cancer, right?
Yes.
Because they are
Yes.
going to leave there still worrying about that unless you verbalize that. So a good way to get that out of them, I mean, you can just, say that. And sometimes we have enough experience that we kind of know what they might be thinking. And sometimes we're going to be wrong about that, but you might want to just outwardly verbalize it. Or you can just ask them, what worries you about that?
Hmm.
What worries you about this? Well, and then they might say, I'm worried about throat cancer. So that helps you to understand why they're really there because they may not say it. It's our job as physicians to get this information out of them. And if you can do it efficiently, it's going to save you time. Another thing that you can do, again, efficiently, is demonstrate compassion. Okay. So, how do you demonstrate compassion efficiently? A simple turn of phrase. Patient comes in my office. They could come into your office with this vertigo, right? They feel like the room's spinning around them. It's a terrifying sensation. It feels awful. Just say that. Just say, wow, that sounds terrifying. That sounds awful. Oh, you were vomiting? Oh, man, that sounds awful. Then they understand that you recognize the severity of the symptom. You recognize what discomfort they've been in. So these little turns of phrases you can incorporate into your practice, and it'll help the patients love you, recommend you to their friends, and it'll help the visits to move. And it seems like it's a little forced, right, to include this stuff in your practice, a little formulaic. There's a lot of stuff that we do in medicine that's formulaic, right?
Let me
How we're
ask
going
you a
to picking our
question.
medication.
Let me ask you a question. One thing that I try and do, whether it's the clinic or the hospital, and I have mixed feelings about it, going to see the patient and there's family members there, one, two, three, maybe a friend. I try and acknowledge them and ask who they are. Oh, are you the sister, the girlfriend, the mother? And then kind of get back to the patient. So I include them. I mean, they're there, right? So
Yeah.
presumably the patient wants them to know what's going on. But it's a lot easier to just walk in and start talking to the patient, and whoever these random people are, they're just there. But I try actually and acknowledge each one of them and ask where do they fit into this patient's puzzle. because I might use that. Okay, you're the wife, so you're going to remind him to take his medicines when he gets home. But it does take extra time. So do you do that or not?
I do it a little differently. I'll ask the patient, and who did you bring with you today?
Oh, okay.
And
Okay.
sometimes the first person that they introduce me to is their stuffed animal because I see a lot of kids. So they'll say, "Oh, this is Snuffles," or whatever.
All right.
They're not going to
Okay.
introduce me to their parents. But then I'll say because the especially since the people in the room might not be who you think they are,
Yes, exactly. Yes.
right? So it'll help you avoid making incorrect assumptions about, you know, mom and grandpa, or mom and dad, or mom and mom, right? Like, just ask, who did you bring with you today? And then, like you said, it's important to acknowledge everyone. Notice their eye color too. So make eye contact with everyone in the room, I think is important. And it's also important, again, to your point, to acknowledge the struggles and challenges of the caregiver, and when appropriate, thank the caregiver as well.
Yes, I often do that. I'll say thanks for coming, thanks for helping, because sometimes I think visitors feel they're an imposition, they're getting in the way. But I feel the opposite. The patients, I see mostly hospital patients, and the patient's going to leave, and if he's got somebody or she's got someone who's going to help with the aftercare, I think that's terrific. So I kind of try and bring them on board. All right, suppose I'm a new patient. I come to see you. I have a hoarse voice. We're going to get to the bottom of it. How long are you going to spend with me in this efficient visit? How many minutes do I get?
Oh, there's no timer. There's no timer because sometimes I might spend a half an hour with someone, and sometimes I might spend 5 minutes with someone.
So as long as it takes.
As long as it takes, but it's important to set boundaries as well, because if it like keeps going on and on and on, right, you might have to say, listen, um, I would love to get to all of your questions, but I do have a couple people in the waiting room. Let me call you later today, and we'll be able to get everything. Or listen, I'm so glad we were able to figure out your ear pain, but you know, when you've got your hand on the door and you're ready to go, and they're like, "Oh, but what about my dizziness? I didn't mention my dizziness." Listen, I definitely want to get to that, and I want to give it the attention it deserves. It sounds like a whole visit unto itself. Let me walk you out, and we'll set you up with an appointment in the near future. And then it'll give me an opportunity to check on that ear pain, and then we'll address the dizziness as well. So, there are ways to manage that. And I'm saying it like it sounds amazing with every patient visit that I have, which is totally not true. I am a work in progress, the same as the rest of us. So it's not like I do this extremely well every time, but it is an iterative process, and I think it's important for us to work on it because it makes things more enjoyable too. It makes things more enjoyable when you're not under that time break. When you don't have five people in the waiting room and all of them are pissed off as soon as you walk in the room, right? It makes the practice. It gets
Right.
rid of
It's
some of
hard
that
to
burnout.
undo that, you
Yeah.
know. And I've been on the other end of that, a patient sitting in the waiting room. It's like, I've been there for an hour. The first thing I want to say to the guy is, how come you kept me waiting for an hour? I already forgot about why I'm there. I'm just irritated that so it takes a while to kind of get beyond that if you've already irritated the patient or your staff
Yes.
has by making them fill out, 2,000 forms that no one's ever going to look at, or giving them misinformation or TV blaring in the waiting room. I think there's a lot of kind of structural things that happen that you were talking earlier about the patient experience. I'm really impressed you even have a patient experience committee. I guarantee that the doctors I go to don't have a patient experience committee because they're not addressing that at all.
Well, the a lot of what we do in the patient experience committee is really staff experience. Like if you read about any of the big names in customer service, American Express, Ritz Carlton, Disney, they all say the same thing. It's about empowering the staff and treating them well. And so, when you walk into the hospital, right, you walk onto the wards, you need to know the names and the faces of the people that work there. Like when you walk into the office, you should be, and I need to work on this as well. Sometimes I show up, I need to just get right to work, but I should be stopping by the front desk. I should be stopping by the back desk. I should be stopping by to, good morning, everyone. How you doing? Know everybody's names. If they're married, try to learn their spouse's names. If they have kids, try to learn their kids' names. Ask them about their kids. I mean, people love talking about their children more than anything. So, this is part of the patient experience. It's part of the patient experience because by knowing your staff's children's names, they know that you care about them as people. In the same way, the patients want to know that you care about them as people. So if your staff knows that you care about them as people, they are going to be more invested in their job and they are going to be treating your patients better. So it all comes down to that patient experience. And yeah, and the more autonomy that you feel comfortable giving them and maybe don't feel comfortable giving them,
Hmm.
the better as well, because that's going to give them a better experience working with you.
So, what advice would you give a ENT resident just graduating and they've got lots of job offers and they have the opportunity to go into private practice or, become an employee at some giant, Kaiser kind of operation? And it looks like private practice is still a viable option. How do they know? What do they do? What questions do they ask to see if it's a good practice or they should just take a job?
Um, well, especially in today's day and age, you need to talk about any potential for a private equity sale, right?
Mm.
Are they looking to get out? Are the partners looking to sell so that you will then go to be an employed position? So that's one question. And if you do sell, what happens to me?
Right.
I would recommend that you include something in your contract such that if there is a sale of the practice, that your restrictive covenant is null and void because you're joining the practice that you're joining. You're not joining the practice that they're selling to. So it should include this that if the practice is sold, that your restrictive covenant is now null and void and you can go work anywhere in the area.
Right. So that means usually a restrictive covenant for those who haven't signed one yet means when you join a group or you get a job that you can't work within a certain radius of that
Yeah.
employer for a certain amount of time, usually a year or two. It might be 1 mile, it could be 50 miles. But if those are meaningless if you stay, but if you
Yes.
leave, they become very important. So I would agree with you, Brad. That should definitely be addressed.
But if you're trying to figure out whether you should join private practice or an employed practice, it really depends, I think, on what you're trying to do, what kind of practice that you want. Um, you know, the things that happen in academic practice aren't necessarily the things that happen in private practice, right? The private practice, we tend to do things that are um, not as complicated, not as involved, or that's not necessarily the case. I know an otolaryngologist who does neck dissections and cochlear implants, which in an academic setting would never happen because you'd either be the otologist doing the cochlear implants or you'd be the head and neck cancer surgeon doing
Ah,
the neck dissections.
mm.
So, whereas in most private practices, you're not doing that. So it really, it's hard to tailor it specific to the without knowing which practice they're going to, what kind of life they're going to have. I mean, I would argue figure out where you want to live
Okay.
first and then narrow it down from that perspective. But for me it was a no-brainer. If you are going to join a private practice though, I would ask them like in the same way that my practice there's a clear path to full equity partnership. Like ask them and have it written down like how do I become partner and what does partner mean? And when they say, well, partner means you're going to get a 2% stake in the practice, like that doesn't sound like a partner. That sounds like a minority shareholder. Like, this whoever started the practice took a certain amount of risk in order to
Right. That's true.
start and build the practice. How much is that worth to them, right? You want to be a partner. How much of the pie do they think is reasonable for you to, and how much do you need to contribute in order to get there? Because I recognize that not everyone's going to be like us and giving everyone a clear path to full equity partnership, but like you need to be upfront about how long that person needs to be working there, how much money they need to make in order for them to get what exactly.
Yes, and I would agree with you that the key is to try and have some self awareness and insight as to what you really want out of this. Is this 100% effort for you? Is this you've got other interests? You just want to make a living? Is this where you want to live forever? Know your why. That'll help
Yeah.
you ask the right questions. All right. Well, we're running out of time. What else would you like to add before we wrap up, Brett?
Well, I certainly want to plug the podcast, but
All right, what's the
um,
name of the podcast?
Physician's Guide to Doctoring. So you can find them on X, I guess formerly Twitter, Instagram at Physician's Guide, on LinkedIn, Bradley B Block, not to be confused with all the other Bradley blocks out there. And or physiciansguide to doctoring.com. Check out my website and you can find links to all the different podcast players there. And it's the tagline is everything we should have been learning while we were memorizing Krebs cycle. So really we cover everything that comes with helping physicians be the best versions of themselves in and out of the exam room. So we cover a lot of breadth to what we cover, and it's all to help us be the best versions of ourselves,
Including locum tenens.
including locum tenens. We love that episode with Dr. Wilner.
Well, Dr. Bradley Block, I want to thank you for joining me on this episode of The Art of Medicine.
Thank you. It's been a pleasure.
Before we close, I'd like to give another thanks to our sponsor, locumstory.com, a resource where providers can get real, unbiased answers about locum tenens. I'm Dr. Andrew Wilner. See you next time. This program is hosted, edited, and produced by Andrew Wilner, MD, FACP, FAAN. Guests receive no financial compensation for their appearance on The Art of Medicine. Andrew Wilner, MD, is Associate Professor of Neurology at the University of Tennessee Health Science Center, Memphis, Tennessee. Views, thoughts, and opinions expressed on this program belong solely to Dr. Wilner and his guests and not necessarily to their employers, organizations, or other group or individual. While this program intends to be informative, it is meant for entertainment purposes only. The Art of Medicine does not offer professional financial, legal, or medical advice. Dr. Wilner and his guests assume no responsibility or liability for any damages, financial or otherwise, that arise in connection with consuming this program's content. Thanks for watching. For more episodes of The Art of Medicine, please subscribe. www.andrewwilner.com